because on Sunday, I forgot that I'm really old, and I was riding my kid's hoverboard and hit a shoe, and it kicked out, and I was also wearing flip-flops, which is twice as stupid, and kind of fell back, and pretty much nothing but the ceramic tile in my house and the back of my head hit, and you know, everything just kind of, I felt every nerve in my body fire at the same time, and I was kind of like numb, just kind of laying there. My son's like, should I call 911? I'm like, yeah. And then he got on the phone with the stupidest 911 operator on the planet. And after like 5 minutes of talking to her, my wife's finally like, screw it, get in the car. Because by then, apparently I got up, tried to walk, got really dizzy, sat down, slid down the stairs, and then blacked out for a few minutes. And he's still on the phone with 911 operator where I got up. Anyway, turns out they did a CT, I just got a concussion. So for the last couple of days, I mean, I can't drive, my son drove me, but last couple of days, it's weird. It seems like I'm dreaming all of this, right? So I think I'm all here, but it feels like I'm dreaming it all. It's really bizarre. Anyway, so we are talking about COPD. So we're moving into that. We already talked about acute bronchitis. And when we talk about COPD, we're talking about chronic bronchitis and emphysema. However, technically, asthma is considered a COPD because it is chronic and obstructive, and it's a pulmonary disease, okay? Now, when somebody says COPD, they pretty much never mean asthma. I'm just telling you, technically, it is in that category. So we will talk about that also, but main thing we're gonna be talking about is chronic bronchitis and emphysema. Now, last time we talked about acute bronchitis, right? When it goes from acute bronchitis to chronic bronchitis, there's a change, okay? There's an actual histological change. Does anybody know what that is? Where you go from classifying something as acute bronchitis to chronic bronchitis? Does anybody know what the difference is between those? All right, good input. So, yeah, you got it?
Yes, so I would say that acute occurs very fast, and chronic is just like for a period of like months and years.
Okay, so chronic, literally, acute and chronic, I mean, acute means it's happening now. People, like we saw last time when we were talking about giving examples, right? You guys have had acute bronchitis. Some of you have had acute bronchitis before. It comes, it goes, you get through it. Chronic bronchitis is a accumulation of, if you've had acute bronchitis for long periods of time, okay? There is a key phrase that happens with changing acute bronchitis, episodes of acute bronchitis into chronic bronchitis. Do you know what that change is? That it actually changes over from acute to chronic. There's a time frame, okay? So think about what's happening. Somebody has bronchitis, and the bronchi obviously are inflamed. Do you remember that? What can cause bronchitis in the first place?
Smoking.
Smoking, obviously a big one. What else? I mean, it's definitely the biggest.
Pollution, just being irritated.
Pollution can cause it, huh?
Dust and pollen.
Dust and pollen. All of these things, these are all irritants. What about the category of infections? I guess that is it, actually, because infections, upper respiratory infections that turn into lower respiratory infections can also be a cause of bronchitis, right? I don't know if any of you guys, again, if you've had bronchitis, sometimes it's because of allergies and things like that, and sometimes it's just because you had some kind of a nasty flu virus or something like that, okay? So here's the thing, is that if you think about what happens with acute bronchitis, right? The bronchi inflame, they get some pus in them. The bronchi, when they inflame out, they also inflame in, right? So the narrowing of the lumen, the place where you can put air, is just smaller, okay? Plus, you get pus in there. Makes it really hard to breathe, so you're constantly coughing out phlegm, you're coughing out stuff, right? Well, there is a point to producing the mucus in the lungs when you have bronchitis. That is, whether it's an irritant or whether it's something else, the mucus kind of catches whatever that is, right? Catches it and then coughs it out, helps with the little cilia, right? Cilias are kind of crowd surfing it out of the body as you cough, that sort of thing. If you do that over a long period of time, and that period of time is that it has to be more than 3 months total in 2 consecutive years, okay? That's like the minimal threshold where the physiologists have figured out that if somebody has acute bronchitis for more than 3 months in a year, for 2 years consecutively, then the lungs are going to figure out, you know what, this is happening so often, we're gonna go ahead and we're gonna make more goblet cells. Okay, what do goblet cells do? Secrete mucus, right? So now you can picture the problem. And that is that now you're making more mucus because you had hyperplastic goblet cells, right? And remember, hyperplasia is creating more natural cells, right? So you have hyperplastic goblet cells creating more mucus, and now it's a chronic condition because you actually have more cells that are creating more mucus, so even the slightest irritation now gets attacked with all of this mucus, right? Which of course narrows the lumen, the place you can breathe, you're coughing up more phlegm, and so forth. So it's actually kind of changes the histology, so it makes it actually worse than it might be otherwise, okay? So at that point is where we say somebody has chronic bronchitis, okay? Because it's always going to be a lot more irritated. Now, having said that, the main reason for chronic bronchitis is, like you said at first, smoking, okay? The vast majority of cases with somebody with chronic bronchitis is that they just smoke a lot and over a long period of time, and it caused the histological change, okay? We call people with COPD, we call them blue bloaters. Any idea why? Blue bloater? No? Okay. When we say blue, we mean their skin is kind of blue. What is another word for that? When their skin is blue? Cyanosis, right? So we say they're cyanotic or they're blue. Okay? Why would somebody be cyanotic? Why would their skin have a blue tinge to it?
Low oxygen.
Yeah, exactly. Low oxygen, actually. So you can picture why they would have low oxygen, right? I mean, they got bronchitis chronically, and they're kind of blue, they're cyanotic. And then we say that they're bloaters, okay? Now, the bloaters kind of goes back to what we were talking about before. Remember when we were talking about cor pulmonale? Remember that? What was the problem with cor pulmonale? Does anybody remember the definition? Yeah? I know somebody said something back there.
Heart failure.
What side of the heart is failing?
Right.
Right side of the heart is failing because, huh?
Blood's not properly getting to the lungs or being properly oxygenated.
Okay, so it has to do with the lungs, right? So that cor pulmonale was right-sided heart failure because of a chronic lung problem, right? And this would be one of those chronic lung problems, okay, is chronic bronchitis. So when somebody's, again, having these mucus and it's creating a lot of pressure in there, right? Because they're having to kind of work to breathe because it's a more narrow lumen, and you got all that mucus, so you're constantly coughing, you're constantly doing that stuff. Well, that actually affects the pressure coming out of that right side of the heart to cause technically it would be an afterload, even though it would be in between the right and the left side of the heart circulation. It's after the right side of the heart. So you'd have this afterload that would kind of make it so that the right side of the heart had to push harder to get in there, right? And then that right side of the heart gets weak. And then the blood kind of backs up into the right atrium, and then it kind of backs up into the jugular veins, right? So when we were talking about cor pulmonale, some of the signs that we were looking for is jugular vein distension, right? Because that blood is kind of, from the venous blood, trying to get back in, and it can't until it kind of pools, and then the pressure from that has a lot to do with it dumping back in the right side of the heart. Plus it had that ascites, right? So, ascites is another word for water in the stomach or edema, right? So, they're blue, cyanotic, they're bloated because they have a lot of ascites, okay? But again, it's all from the lung problem that probably caused cor pulmonale also. So, does that make sense? Why we call them blue bloaters? Okay.
Do you need a projector too? Is it that?
Yeah, that would be good. It's just gone.
Okay.
No idea what the problem is with that thing. Okay? So you gotta mess with all that? That's fine.
Yeah.
That's cool. You guys have the PowerPoints. I don't really need them. So, so what are the big keys? What are the big buzzwords with chronic bronchitis? How is it you're going to recognize these in a case study or with patients?
Bouts of acute bronchitis for 3 months for 2 years.
Okay?
Ascites,
Cyanotic,
distended jugulars.
ascites, distended jugular veins. Good, good. And again, that history of acute bronchitis for a long time is going to help too. Highest risk factors, of course, are going to be smoking, right? What were some of the other ones? Some of the other risk factors for chronic bronchitis?
Did we say pollution?
I think we did say pollution, which is the same risk factors for acute bronchitis, really, right? So, you know, that's going to be your clinical scenario. With emphysema, who can tell me anything about emphysema? You may have seen that one before in prior classes. Huh? Pink puffers, we call emphysema pink puffers, okay? Why do we call people with emphysema a pink puffer? Okay, I actually heard it when I was asking why people say that the chronic bronchitis patients are blue bloaters. Someone actually gave me the reason on why you have pink, why you're a pink puffer. I don't know if you heard that or not. One of you guys said because of CO2, okay? And that is the reason. Now, if you think about with emphysema, okay, first off, let's back up a second. What is it? What is emphysema?
Destruction of the alveoli.
Okay, destruction of the alveoli. Let me grab my bag here. So, what you will see in your PowerPoints is that the alveoli are destroyed. So if you're looking at the lungs, right, and you know you got to the end, wherever the end was, and you got your alveoli, right? Okay. What happens is these walls of the alveoli, they actually get destroyed. Okay. There is a slide that you guys have that talks about neutrophil elastase and how that fits in there. But basically what happens is that alveoli, where you're actually doing your gas exchanges, right? Your CO2 is supposed to be going out of your blood, and you know, obviously a different alveoli or whatever, but oxygen is supposed to be coming in, right? If you destroy those walls of the alveoli, and that's where gas is being exchanged, you have a lot of trouble, okay? Because the alveoli, one of the things about alveoli is that they kind of move, okay? Think about your lungs, right? Well, the alveoli are like your functional unit of your lungs, so they actually kind of collapse the alveoli and expand, okay? Does anybody remember why they can expand after they collapse? This is something that might have been talked about in one of your prior classes. The alveolar walls, what is special about them? It has to do with surface tension, some fluid. Surfactant, exactly. So on the inside of an alveolar wall, you have a very thin light coating of this fluid. It's kind of like an oily water almost, right? It's called surfactant, okay? Surfactant is going to be the thing that's creating surface tension, okay? So this is the part where you might have seen it in a prior class, maybe in Bio 211, when you were talking about surface tension and hydrogen bonds, right? So what happens with this water is you have the hydrogen bonds kind of holding things together, and if you make them smaller, the hydrogen bonds bond tighter as this thing gets smaller, right? But then you're kind of crunching the bonds together a little bit, so then it makes it a lot easier for them to keep that surface tension and then pop back open, okay? So, these alveoli, they're used to going like this, breathe in, breathe out, right, kind of thing. When they're doing that, that's actually helping them exchange the gases. The net result is if you lose these walls of the alveoli, instead of having a bunch of little alveoli with a lot of surface area, right, because every one of those walls, gases are being exchanged on all of it, you lose a whole lot of surface area to start with, and you lose the ability of that alveoli to contract and expand. So what tends to happen is you tend to get CO2 trapped inside the lungs, okay? So breathing in, actually not that big of a problem for somebody with emphysema. They can breathe in, they can get their gases exchanged, but getting the CO2 out is the problem, okay? So what happens with somebody with emphysema is CO2 and carbon monoxide, for that matter, both. If you have too much of that in your blood, it kind of turns your skin a little bit pink, okay? Somebody with carbon monoxide poisoning, for example, they're like cherry red. There's like a buzzword for that. They're like red, okay? Like they got a serious sunburn all over their body. With CO2, tends to turn them a little bit pinkish, okay? So that's the pink part of it. Can I grab that chair?
Oh, yeah, sorry.
The other part of this is that this CO2 is trapped in these pockets, and if you see somebody who has emphysema, they're kind of like sitting forward a little bit because if you think about that, kind of compresses their diaphragm up into their lungs a little bit, right? So they're kind of sitting forward like that, and because they need more pressure to help get that CO2 out of their lungs, they purse their lips and they kind of puff. They're like this, and if you do that, you can practice if you want. If you actually do that, you can feel all of these accessory breathing muscles all the way through your chest and your neck. They're all being used, right? So they're creating that pressure to kind of push that CO2 out, and they look like they're puffing, like that, right? So that's why we call them a pink puffer, because they tend to be a little pinker. They're not cyanotic as much. Although, having said that, emphysema and bronchitis, both of these patients, you can absolutely see them walking around with their little nasal cannula with their little oxygen tank, you know. A couple of years ago down at the bus stop there on 27th Avenue, saw some lady sitting there on the bench waiting for a bus, had her little oxygen tank, you know, and her nasal cannula is in there, she's smoking a cigarette. Like, all right, all right, says it all right there. But anyway, so that would be the pink puffer again. The thing with emphysema is it's creating these air pockets, okay? Air pockets inside the lungs, and you can actually see that in a variety of ways. So if you're looking at an X-ray, for example, think about this, these alveoli, all these alveolus? I don't know which is singular and plural. Alveolus, alveoli? I think alveoli is plural. I've been saying plural the whole time. Think about the alveoli not having those walls, and technically, there's actually more space, isn't there? Right? Think about this classroom, right? Think about the amount of air molecules you could put in this entire classroom, okay? And then take all of us and take all of the furniture out of here. You could put more air in this classroom, couldn't you? Because we're physically taking up space where air could be. Well, it's the same here, where this one with emphysema, because of the destruction of those alveolar walls, technically you can put more air in there, and you actually can see that on an X-ray. You look at an X-ray of the lungs, and remember the dark, the black on an X-ray is air. It looks like they have huge lungs, okay? So there's just, everywhere is just black, assuming they don't have an infection, you know, making infiltrates or something, but you just see huge lungs, because technically they can actually put more air in their lungs, right? That's not really the problem. The problem is getting it out because of the destruction here. And of course, exchanging the gases is the problem. So we say that they have an increased total lung capacity over normal, okay? You would think that would be a good thing, right? But obviously it's not, because you have an increased total lung capacity because you don't have walls on your alveoli, so you can actually exchange gases, okay? So you can see that on an x-ray. You can also see it if you take an x-ray, turn them sideways and look sideways on and take an x-ray there. They say that the anterior, posterior diameter is also bigger. Okay, because again, you've got holes. You got all these big spaces in somebody's lungs. Okay? So again, that's some of the things that you'll tend to hear about when you're talking about emphysema is increased anterior, posterior diameter on x-ray. That's what they're talking about. Also, that whole idea of the barrel chest, again, a big buzzword for emphysema is barrel chest, okay? For two reasons probably. One, because you do have that increased anterior, posterior diameter, kind of makes it look a lot more rounded, but their chest itself is probably a lot more rounded also, just because if you think about it, when I was sitting down there and doing that, and you're using all of these accessory muscles that you normally don't use those accessory muscles to breathe unless you're exercising, right? Doing cardiovascular exercise, but now you are using those and you tend to build them up so your chest kind of gets all barreled. Is that bad news?
Well,